way, because I'm going to use some terms sort of interchangeably, but I just want to be clear on what exactly I'm talking about. So when I'm talking about psychopathology, I'm talking about the signs and symptoms of mental illness. So what are the actual diagnostic criteria that we use to define mental disorders? When I'm talking about abnormal psychology, I'm talking about applying the principles of psychological science to the study of psychopathology. All those things that you guys have heard about all semester long in terms of the scientific method, hypothesis testing, experiments, and so on, when we apply that to understanding mental disorders, that's what we're talking about with abnormal psychology. And finally, when I say syndrome, I'm talking about the symptoms that appear together and are presumed to define a mental disorder. Okay, so getting those definitions out of the way, here's what I'm going to talk about for the next two classes. I'm going to go through some of the most common myths that there are about mental illness, about mental disorders. These are things that I hear all the time from students who take my class, things that they've heard, things that the lay media reports, sort of common urban myths about mental disorders. I want to go through these and talk about whether they're true or not and what the evidence is for and against them. So that's what we're going to do this week. Okay, first myth, and you wouldn't believe how many people actually think this, is that there's no such thing as mental illness. There's a very famous man named Thomas Szasz who actually proposes that there is no such thing as mental illness, there are no such things as mental disorders, that really what we're talking about are just sort of problems of living. And we can pretty much say that that is a myth, that there are real things called mental disorders that people can suffer from. So this one is definitely a no. And let me start by giving you a case study. The Ch14-Psychological quadruplets. Very, very interesting case study in terms of mental disorders. So these were identical quadruplets born in the 30s. Identical quadruplets. So think of identical twins times 2. This is the same egg that's split in 4. 4 genetically identical sisters. Only happens about 1 in 16 million births. So they were pretty unique. But it became clear over time that they all had varying degrees of problems. And not surprisingly, if you knew their parents. Their parents were Gertrude and Henry. They met in the 1930s. Gertrude found Henry pretty annoying, but eventually agreed to marry him after he threatened suicide. Gertrude eventually became pregnant, and they had the quadruplets, who you can imagine people are pretty excited about. 4 identical quadruplets. So the family made quite a bit of money having people come through the home to actually view them. If you can imagine, there was really no TV, nothing else to do in town, so 4 identical quadruplets were pretty exciting. But their father had some issues. He and the mother apparently had nervous breakdowns, or what they called nervous breakdowns at the time. And they had these weird ideas about the girls. They believed that the girls represented one person split into 4. All of them eventually had a psychotic episode of varying severity. At a certain point, someone alerted the National Institute of Mental Health to their case, and NIMH invited them to Washington, D.C. to be studied thoroughly. And NIMH gave them these pseudonyms, Nora, Iris, Myra, and Hester, NIMH, very clever, and they were studied very extensively. And it turns out that all 4 of them were suffering from schizophrenia of varying degrees of severity. So schizophrenia is really one of the most severe mental disorders, and what we think of is really the cancer of mental illness. And a lot of people get confused between schizophrenia and multiple personality disorder. So if you take nothing else away, please take away this. Schizophrenia is not multiple personality disorder. It's an easy confusion because schizophrenia literally means splitting of mental associations. But we're not talking about splitting a personality. It's a different disorder. We'll get to that one. When I'm talking about schizophrenia, I'm talking about a disorder defined by these different types of symptoms. Positive symptoms, negative symptoms, and disorganized behavior. Positive symptoms are an exaggeration. They're an addition of behavior. Things like delusions, hallucinations. Believing that someone's out to get you is a very common delusion. Auditory hallucinations, hearing things that other people can't hear. Visual hallucinations and even tactile hallucinations are possible as well. Auditory are by far the most common. And then we're talking about disorganized behavior, like, here's an example of disorganized speech. So this is from an actual interview with a patient suffering from schizophrenia. Interviewer says, have you been nervous or tense lately? Patient, no, I got a head of lettuce. You got a head of lettuce. I don't understand. Well, it's just a head of lettuce. Tell me about a head of lettuce. What do you mean? Well, lettuce is a transformation of a dead cougar that suffered a relapse on the lion's toe. And he swallowed the lion and something happened. See the Gloria and Tommy, they're two heads and they're not whales. But they escape with herds of vomit and things like that. So there's grammar there, right? There's some vocabulary, there's grammar, there's syntax, but it doesn't make any sense. It's very disorganized. It's essentially word salad. And this is what the Ch14 quadruplets had. They had varying degrees of schizophrenia. Now, some of them did better than others. One of the sisters actually managed to hold down a job for most of her life, get married, have a family. She was the only one who did that, Theo. The other three never managed to have a family or get married, and they had varying degrees of success with work history. So we know today that the Ch14s had a real mental disorder, and they suffered disability as a result of it. But earlier in history, society would not have been as kind to them. We know from historical records that syndromes that we now recognize as mental disorders, have been in historical writings for thousands of years. Theologians, priests, ministers, rabbis, shamans have all described various forms of what we now know to be mental illnesses. References to abnormal behavior have been found in ancient accounts from Chinese, Hebrew, Egyptian societies. And many of those writings attributed abnormal behavior to disfavor of the gods or ancient demons. Less supernatural accounts of psychopathology can be traced back to Greek physician Hippocrates, who hypothesized that abnormal behavior, like physical problems, had natural causes. And this was pretty revolutionary. So he diagnosed and treated what we would now call mania, paranoia, hysteria, and challenged the belief that mental illnesses were the result of disfavor of the gods. Now, from Hippocrates up through the Middle Ages, we don't see a lot of progress here. Many mentally ill people before even the 19th century were treated as criminals and thrown into prisons or lunatic asylums. This picture over here represents a convent, an asylum that King Henry VIII granted a charter for at the Hospital of St. Mary of Bethlehem, which became known as Old Bedlam. This was not a place you wanted to go if you had a mental illness. Inmates were locked up, they were chained, they were fed slop, they were given purges, they were subjected to bloodletting. Not very humane conditions. Now we move forward to the 19th century, 18th and 19th century, when there was a confluence of events. There were researchers like Emil Kraepelin here, who's really what we consider the father of scientific psychiatry, and started to lay down a classification of what we call mental illness. In addition, people like Pinel in France were starting to really revolutionize how asylums were run. A moral treatment movement arose in Europe and the US, which really proposed that people with mental illnesses needed to be treated humanely in order to get better. So Pinel, for instance, gradually changed the conditions of the asylum that he was the director of. Chains were removed, food was improved, he ended things like bloodletting. And in the US, there arose a far larger number of asylums, both public and private institutions. By 1880, there were 75 public hospitals in the United States with a total population of more than 35,000 residents. And the heads of these institutions in the United States would eventually become the American Psychiatric Association. The superintendents of these large mental institutions got together, and formed what would later become the American Psychiatric Association. So, the take-home message here is there is such a thing as mental illness. Mental disorders do exist, and especially over the last 200 years or so, researchers and scientists have put a great deal of effort into trying to classify and categorize how we understand mental illness. So, leading to the second myth, which is very closely related to the first one, the idea that mental illnesses are not real disorders. That, okay, maybe mental illness exists, but it's not really the same thing as a physical illness, that maybe people are just crazy. That one is definitely a no, too. That group of superintendents of asylums, who eventually became the American Psychiatric Association, actually got together and created a manual, which is now in its 4th edition, called the Diagnostic and Statistical Manual of Mental Disorders. And the Diagnostic Manual was created in order to have a manual of how we classify and categorize mental illness in the United States. Especially following World War II, it became really obvious that we didn't have a uniform system, either in the military or in private hospitals or psychiatric institutions. There was no uniform standard for identifying whether a person had a mental illness. If they did have an illness, which one was it? And this really held back treatment. If we don't understand what kind of syndrome a person has, it's hard to develop the most appropriate treatment for them. So, eventually, the American Psychiatric Association published a Diagnostic and Statistical Manual. The first edition came out in 1952. The second edition came out in 1968. The third edition came out in 1980. There was a revised edition in 1987. The fourth edition came out in 94. And this is the most recent version. It's still the fourth edition, text revision. They did some changes to the background text, and that was in 2000. And the 5th edition of the Diagnostic Manual is due in the next year or two. So they are furiously working now on revising the current DSM. And there's some actually pretty controversial changes included. So if a clinician, whether that's a psychiatrist, psychologist, physician, what have you, when a clinician wants to diagnose a mental disorder, we go to the Diagnostic and Statistical Manual, and it lists over 200 different types of mental disorders grouped into these 18 categories. And these groupings are roughly based on shared symptomatology. And that was an idea of, if we go back, Kraepelin. Kraepelin was actually pretty revolutionary in suggesting that we need to group disorders together by shared symptomatology. So, Diagnostic and Statistical Manual identifies these 200-plus diagnostic categories. There's also a general definition of mental disorder that all of these diagnoses share, and that is this: a clinically significant behavioral or psychological syndrome with present distress, disability, or an increased risk of suffering pain, death, disability, or loss of freedom. So this is how we identify a mental disorder, that these things have to be present. It doesn't mean the following. So these are things that we do not include in the Diagnostic and Statistical Manual of a mental disorder. Expected and culturally sanctioned responses. What do I mean by that? Well, a classic case is bereavement. If you lose a loved one, if you lose someone close to you, it's expected that you will have a period of sadness to mourn that loss. And we call that bereavement. And that's completely expected and very normative. We would not include that as a mental disorder. as opposed to a major depressive episode, which lasts for a certain period of time, includes a certain number of symptoms, and we can definitely distinguish as being different from a natural period of loss and sadness. So we also don't include deviant behavior. So our friend here, even though he looks like maybe there's something going on with him, just because he chooses to look different or act different from the mainstream, we wouldn't include that as a mental disorder. And we don't include conflicts between the individual and society. So even though a person may go out of their way to act in a way that we would not expect based on their culture or society, they may even go to the extremes and use violence against members of their society, they wouldn't necessarily have a mental disorder. Okay, so the Diagnostic and Statistical Manual of Mental Disorders, like I said, is published in the American Psychiatric Association. And the American Psychiatric Association is psychiatrists. They're medical doctors, right? And even though there are psychologists on the committees that help to make the Diagnostic and Statistical Manual, it's a combination of psychiatrists and psychologists, it's still dominated by the psychiatric view of mental illness, which is really a medical model. The idea that if we study it long enough, we can figure out what the causes are, and once we know what the etiology is, we can figure out the best treatment and we can even cure it. So even though the Diagnostic Manual is atheoretical as to causes, it really doesn't speak to causes of mental illness. It basically just lays out what the signs and symptoms are, it tells you what prevalence is, it tells you how to make differential diagnoses from other disorders. It doesn't really lay out what the causes of all of those 200 plus disorders are. It's sort of implied that it's a medical model. But many psychologists and others disagree with that view of mental illness as a medical disease. Now, the Diagnostic Manual does encourage all clinicians to assess their patients on 5 different axes. And all that basically means is that there are 5 different things that any clinician using the Diagnostic Manual needs to assess for. The first axis is what we think of when we think of mental disorders. They're clinical, acute problems like schizophrenia that the Deneen quadruplets had, like major depression, like anxiety disorders. Sort of the classic things we think of when we think of mental illness. The second axis are personality disorders. And personality disorders are chronic, long-standing problems defined by maladaptive personality traits. And in fact, some people suggest that the Big 5 model of personality, Ocean, you guys have heard of that, that if you just look at the most maladaptive ends of that Big 5 personality trait, you could probably replace axis 2. You could probably replace the personality disorders with some combination of those 5-factor traits. But not everyone agrees on that. And right now there are 10 personality disorders defined by, again, various combinations of maladaptive personality traits plus disability and impairment. Now, it's a little bit different with personality disorders because part of the problem with personality disorders is people don't usually know that they have one. People don't sort of have the insight to acknowledge that they have a problem with their personality and that that personality disorder is causing them problems in life. No one really wants to acknowledge that they're narcissistic or that they are antisocial or that they're paranoid. Now, personality disorders were separated from the Axis 1 disorders to encourage clinicians to really do a comprehensive evaluation of a person's functioning. Because when they were all grouped together, they were kind of getting lost. The clinicians were just kind of going straight to a clinical acute disorder like depression or schizophrenia and not doing a thorough assessment of maybe there's personality pathology there as well. Now, for DSM-5, interestingly enough, the suggestion at this point is to go back to how it was and move the personality disorders back onto the same axis as clinical disorders. We'll see if that actually ends up happening. Now, axis 3 encourages clinicians to assess for any kind of medical condition which might impact both the cause and the treatment of a mental disorder. Same thing with Axis 4, any kind of psychosocial stressors that are going on. How's the patient's relationships? How's their work history? How's their family support? All of these things can both inform the cause of a mental illness and how treatment is going to work. Because if there's very little family support, for instance, you're not really going to rely on family therapy to help treat this person's problem. And finally, Axis 5 is a global scale from 0 to 100, with 100 being great, 0 being very poor, of how well functioning this person is doing right now. It's a quick snapshot of a person's functioning. So here's what the current DSM looks like. It is a categorical system of classification. Like I said, 200 plus disorders, roughly grouped into these 18 headings. So here's the mood disorders heading. Under the broader heading of mood disorders, the diagnostic manual breaks it down into depressive disorders and bipolar disorders. And these are all disorders of mood in the sense that there's something disturbed about mood. With depressive disorders, you're in a very sad mood, you're in a very depressed mood. And that can either be a major depressive disorder, a dysthymic disorder, which is less severe but more long-standing, or a depressive disorder not otherwise specified. That's what that NOS means, not otherwise specified, meaning you have symptoms that look like a depressive disorder, but you don't technically meet the criteria for a true major depressive disorder. And then bipolar disorders, which are a combination of that sad mood and an elevated mood. Interestingly enough, Catherine Zeta-Jones, famous actress, came out recently saying that she had sought treatment for bipolar II, which is a less severe bipolar disorder in which episodes of depression alternate with episodes of elevated mood. Not quite mania, as we see in bipolar I, but elevated mood. Bipolar I has a true alternating manic episode with a depressive episode. And in that manic episode, a person feels like they're on top of the world, almost grandiose. They can do anything. They're not afraid of anything. They feel like they're Superman. And that alternates with these very depressive episodes where they have a loss of interest or pleasure in pretty much anything. So to qualify for a diagnosis, you have to meet a certain number of criteria as specified by the Diagnostic and Statistical Manual. Here's part of the criticism of the manual. For a major depressive episode, you have to meet 5 of 9 criteria. Why 5 of 9? There's not that much empirical evidence that someone with 5 is qualitatively different than a person with 4. And is a person with 6 that much different from 5, and so on. So, once you meet the certain number of criteria as laid out by the Diagnostic and Statistical Manual, you technically qualify for the diagnosis. And that has a lot of practical implications in terms of treatment, reimbursement, all kinds of things that can affect your daily living. Many, many health insurance plans won't cover psychotherapy or other types of intervention unless you have a diagnosis as defined by the Diagnostic and Statistical Manual. So many people have questioned whether this categorical system is really the best way. So let's take a look at what this looks like for major depression. Major depression, for instance. So major depression is, as you might have heard, the most common mood disorder. For a diagnosis of major depression, you need to meet criteria for a major depressive episode, meaning that you have to have 5 of these 9 criteria, more days than not, for at least 2 weeks. And at least one of them has to be 1 or 2, either the loss of mood, or the sad mood, or the loss of pleasure, what we call anhedonia. Loss of interest in your usual activities. You're not getting any enjoyment out of the things that usually make you really, really happy. Now, in addition to that, you have to have enough others to make up 5 of these 9. Now, those of you who can kind of do the math on this one can see that two people who both meet criteria for a major depressive episode can share only one of these 9 criteria. So for instance, you could have 1, and then 3, 4, 5, and 6. Someone else could have 2, and then 6, 7, 8, and 9, meaning you'd only share 6. This is another criticism of the diagnostic manual. Two people with the exact same disorder can look very, very different. Just like the Janine quadruplets, they all had the same disorder. They all had schizophrenia, but the symptoms they each had were different, and the amount of severity and associated impairment that they had were different. Okay, so if I'm a clinician, I need to assess my patient for whether or not they have a disorder, because I need to know how to treat them, and treatment may differ depending on what type of disorder they have. So how am I going to assess a mental illness? Well, there are a couple different ways. Many clinicians will rely on self-report of the patient. And this works for many disorders where, like depression, a person is suffering. A person with depression knows that they are unhappy, knows that they're sad, and is willing to admit that and has some insight into the fact that they have an illness. People with anxiety disorders, they also have insight into the fact that there's something wrong with them, that they shouldn't be afraid of going out in public, that they shouldn't be afraid of heights, that they shouldn't be claustrophobic. They have insight into the fact that there's a problem. For other types of disorders, it's a little harder. Like I said, with personality disorders, it's a little harder to use self-report because people don't want to admit to having these criteria because many of the criteria are pretty negative. With, for instance, the criteria for narcissistic personality disorder, how many of us in this room would admit to being jealous of other people, of always having fantasies about power and success, of thinking other people are jealous of us? Even if we actually did think those things, probably not many of us would want to admit it to another person in an interview. So, again, many clinicians do rely on self-report, but it's not the only way. There are structured interviews that have been designed to go along with the Diagnostic and Statistical Manual. Structured meaning a clinician follows a structured series of questions to assess for all of the criteria in the Diagnostic Manual. So that's one way to do it. It's very costly and it's very time-consuming because think about the fact that there are more than 200 different types of mental disorders. They all have varying numbers of criteria. You start to do the math, and that's a lot of criteria to have to go through to assess a person completely for every possible mental disorder. So a lot of the times we kind of skip through it and go to the section where we really think it's most important. Because if a patient comes in complaining of being sad, well, I'm probably going to skip to the mood disorder section and do that one. You can also get report from family members and friends, and this can be important. Informant report generally can be pretty useful. Although, research consistently shows that the correlation between self-report and informant report of mental disorders is pretty low. Sometimes as low as 0.2 or 0.3. So there's some agreement, but there's also disagreement. And it's not clear in which case we should use a patient's own report and in which case we should use the report of their informant. When does the patient know himself better than a spouse or a parent? It can be a tough question. Another form of self-report, which can be a little more objective, are objective inventories like the MMPI-2. The MMPI-2 is the second edition of the MMPI, Minnesota Multiphasic Personality Inventory, which is one of the most widely used measures of psychopathology in the field. It was originally designed to be a comparison tool. It has more than 500 questions. A person goes through and fills out this questionnaire, and based on their responses, they're compared to a standardization sample. Sort of like an IQ test, right? So they're compared to a standardization sample, and their profile on the MMPI is compared to people with varying types of mental illnesses. So the pros of the MMPI-2 The advantages are the fact that it is a little less obvious what you're asking. So it's a little less obvious that what you're trying to get at, and so a person may answer a little more freely. The disadvantages are that the original sample that it was normed on, well, it's not clear how much that kind of transfers over to current mental illnesses. So newer structures have been developed, new scales have been developed, but it's still not clear whether those are the best. Okay, another difficulty with assessing and diagnosing a mental disorder is that where is the line between normal and abnormal? So you can go through the diagnostic manual, you can find the 9 criteria for a major depressive episode, and you can go through and assess whether a person has any of those 9 criteria. But the problem is that some disorders seem to be more on a continuum with normal functioning, whereas other disorders seem to be a clearer break from normal functioning. So some disorders like schizophrenia, like the Genane quadruplets, are so severe that people really don't have insight. They don't really understand that they have a problem. That person who was talking with the word salad, with the head of lettuce, that person probably would have no idea that they weren't making any sense and they weren't being logical. So that seems to be a clearer break from normality than something like depression, where a person doesn't realize that they're sad, that they're not functioning at their normal self, and that might be less of a clear break from normality and more of a continuum. So let's look at an example of anxiety as one example of this continuum of severity. Now, all of us normally have a certain amount of anxiety which rises in certain situations, right? Just before a big test or a big performance, a special event, we naturally get more anxious. And there's sort of an arousal curve, right? Where at the peak of the arousal curve, we actually do our best. That a certain amount of anxiety actually propels us forward, and we do better on exams, we do better on our race, we do better on our performance, what have you. So that's normal anxiety. But there's also abnormal anxiety, where it goes too far. It's not normal to be afraid of heights. It's not normal to be afraid of enclosed spaces. It's not normal to be afraid to even leave your home. That is a disorder, agoraphobia, where people are literally confined to their homes for years at a time because they're afraid to go out in public. That's not normal. But you can see a sort of continuum between anxiety on the very more normal end and anxiety on the abnormal end. It's an extreme. I'll come back to that in a second. So a few caveats about classification, a few caveats about the Diagnostic and Statistical Manual. It is a living document and it undergoes changes. In fact, there was a major revision from DSM-2 to DSM-3. In fact, there's actually quite a bit of time between all the DSMs, from 1952 to 68, 68 to 80, 80 to 87, 87 to 94, and really, it's been since 94 that the actual criteria changed. So think about how long that's been. Were you guys even born in 94? That's how old the DSM criteria are at this point. And the reason for that is to give researchers, to give psychologists enough time to then go out and do empirical research, to get feedback from other researchers, can inform the process. So from DSM-2 to DSM-3 in 1980, a major revision occurred. A man named Bob Spitzer took the helm of the revision process and radically changed how disorders were diagnosed. Prior to DSM-3, instead of having those explicit criteria that I talked about, each disorder was defined by a narrative paragraph. So you'd open the DSM-2, and you'd see a narrative paragraph describing what a prototypical case of depression looked like, or a prototypical case of schizophrenia. And you would try and match it to your patient. You can see a lot of drawbacks there. And in fact, the reliability between clinicians was pretty horrible. If you gave 2 clinicians the same patient and said, diagnose this person, their agreement was really, really low. So in 1980, with DSM-3, for the first time, explicit criteria were laid out, and this improved agreement among clinicians dramatically. Other things that change are the actual disorders that go into the DSM. So believe it or not, homosexuality was actually included as a mental disorder prior to the DSM-3. Homosexuality was included as a mental disorder. Huge controversy. The fact that your sexual orientation might define you as having a mental disorder. Thankfully, that's gone now. So that's just a way of saying that the DSM is this living document. It is going to go change as science changes and, quite frankly, as a reflection of socio-political pressures. So, especially when Bill Clinton was president, this idea of sex addiction as a disorder got a lot of press. People thought sex addiction really ought to be included in the diagnostic manual as a real disorder. And so that's something that each committee for each of the DSMs has to think about. Should a disorder be included in the manual? If so, how is it going to be defined? Here's a really controversial diagnosis. Dissociative identity disorder. This is the one that gets confused with schizophrenia all the time. So it's a different disorder. It's included in a class of disorders called dissociative disorders. The defining feature, or sort of the thing that links all the dissociative disorders, is a loss of memory, identity confusion. One of these disorders, dissociative disorders, is a dissociative fugue state. And dissociative fugue, a patient with this disorder will wake up thousands of miles away from home with no clue how they got there and no reason why they are where they are. So we're not just talking about a wild and crazy weekend, we're talking about true loss of memory for how a person ended up where they are. So this is a group of disorders that dissociative identity disorder is in. So dissociative identity disorder was previously called multiple personality disorder. And it's really made famous by a few very famous case studies. Three Faces of Eve was actually based on a real person. Sybil, the movie with Sally Field, based on a real person. There's now a Showtime movie, United States of Terra, which gets a lot of press. Dissociative identity disorder is incredibly controversial. It is included in the diagnostic manual now, so it technically is a mental disorder. Most people diagnosed with dissociative identity disorder are women, and most of them report being severely abused as children. And the most common theory of DID is that children cope with abuse by pretending that it's happening to someone else, and they dissociate their mental state from their physical state. And that dissociation results in a new personality. So the dissociative state takes on its own identity. And you can have 2, 3, 4, however many of these different personalities living inside you at the same time. And those different identities differ in things like gender, sexual orientation, age, language, hobbies, interests. Here's why it's controversial. The number of cases skyrocketed in the 1990s. It went from maybe a handful to thousands. All of a sudden, people were kind of coming out of the woodwork claiming they had DID. Many researchers who are skeptical about DID as a disorder claim that the people who think they have DID may have ulterior motives for claiming it. And in fact, there have been some very famous cases of people committed a pretty horrific crime claiming they did it, but they had dissociative identity disorder, and so it was another personality who did it. It wasn't them, it was this other person living inside them. So, controversial that way. In addition to the number of cases really skyrocketing in the 90s, all of a sudden, people were claiming not just 2 or 3 or 4, but dozens, hundreds of different identities. So, it started to look very suspicious that all of a sudden there were more cases, and the cases that were appearing were claiming lots and lots of these identities. And some researchers remain convinced that the disorder doesn't really exist, that really it's more a reflection of people developing this idea of having multiple identities after seeing clinicians who really believe in it. There seem to be a handful of clinicians who are very, very convinced it exists, who sort of become experts in it. And that the disorder itself might just be a reflection of the clinician really wanting a client or a patient to have this. Okay, so that's a controversial diagnosis, still in there, still is technically a mental disorder, but controversial, and there are others like it. So that's one thing. As the committee goes into DSM-5, they're going to have to decide which disorders currently in the manual are going to stay there, and are there any new ones that need to be added. Another thing they're really going to have to address is, are disorders really categorical? It's a huge question. Many, many researchers now think that a categorical way of diagnosing mental illness is not the best way, that really disorders are dimensional, that they lie on a spectrum that I was talking about, from normal anxiety to abnormal anxiety, and that mental illness is the extreme maladaptive end of that spectrum. So many disorders are sort of thought to be more dimensional than categorical. And here's one way of looking at this. So researchers have done some fancy statistical modeling of the most common types of mental disorders. Things like major depression, dysthymia, generalized anxiety disorder. That's 6 months of kind of persistent fear and worry and concern about a diffuse number of events. Agoraphobia, that literally being afraid to leave your home. Social phobia, specific phobias, panic disorder. All of those types of disorders are really when distress and concern is turned inward. So they've been called internalizing disorders, turning your distress inward toward yourself, as opposed to disorders like alcohol, drug use, conduct, antisocial behavior, in which you're turning your stress outward. You're externalizing your pathology. So researchers have found that the reason all of these things are correlated and all of these things are correlated is because you can find these latent factors of internalizing and externalizing. And that maybe the better way to group disorders in the diagnostic manual isn't to group them into things like mood disorders or anxiety disorders, but into these broader categories of internalizing and externalizing. It's not to say there aren't problems with this way of conceptualizing as well. I mean, certainly there's a correlation between internalizing and externalizing. You see quite a few people, for instance, who have a major depressive disorder and an alcohol use disorder. Those two things are often very highly correlated. So it's a possibility. This is one thing they're considering for DSM-5, is reconceptualizing the disorders this way. Certainly not a done deal, but it'll be interesting to see. Okay. Here's another very common misconceptualization of mental illness. The idea that people with mental illnesses are insane. So let's be very, very careful about what we mean when we say insane. Insanity is a legal term defined as the inability to understand that certain actions are wrong at the time of a crime. So they're not overlapping. Well, I should say they are overlapping, but they're not completely overlapping. A person can claim insanity because of a mental illness, but doesn't mean that just because you have a mental illness or disorder, you are insane. So here are a few very famous cases where defendants have used the insanity defense. John Hinckley Jr., very famous case. John Hinckley Jr. was the man who shot President Reagan back in 1981. The Secret Service was not lax, but a little more open about their security at the time, so Hinckley actually managed to get right up next to Reagan as Reagan was leaving a hotel in downtown D.C., shoot him, a Secret Service agent, and Reagan's press secretary, Jim Brady. And it turns out that Hinckley did this because he'd become obsessed with the actress Jodie Foster. Jodie Foster, we know who that is? Yes, okay. So Jodie Foster had just been in the movie Taxi. She was pretty young. Hinckley had become obsessed with her and decided as a way to impress her that he would go shoot President Reagan. definitely sounds a little wacky, and his defense attorneys claimed that he was insane at the time he committed the crime. Now, at that time, the standards for insanity in D.C. were a little bit different, and he actually got off. He got off by not guilty by reason of insanity, and he's been housed at a psychiatric facility, St. Elizabeth's, in D.C. ever since that time. He gets some days off. He gets to go visit his mom every once in a while, but he's basically housed there and probably will be for life. Some other cases. Jeffrey Dahmer. You probably remember Jeffrey Dahmer committed a series of atrocious murders between the late 70s and the early 90s. Cannibalism was involved. He claimed insanity, and it actually didn't work. He was sent to prison and later killed in prison. Lorena Bobbitt, do I have to remind everyone who that is? Okay. So she actually used it and got off. She was found not guilty by reason of insanity, whereas Andrea Yates, who drowned her children in a bathtub, probably from a postpartum psychosis of some sort, tried not guilty by reason of insanity, but had the misfortune to be in Texas at the time where it just didn't work, and they found her guilty. I believe on retrial it actually did work, but the first time around it didn't work. So you can start to see that the insanity defense is not a cure-all for these people. Sometimes it works, sometimes it doesn't. In fact, it's used in less than 1% of felony criminal cases. Less than 1%. Of those, 25% are found not guilty. So an incredibly small percentage of people who try to use the defense are actually successful. But because of Hinckley, because Hinckley got off, and this angered so many people, especially people who liked President Reagan, the federal law actually changed. So they changed the federal law regarding insanity, and they said, here's what the new law is. At the time of the act, as a result of severe mental disease or defect, you were unable to appreciate the nature and quality. You were unable to appreciate that what you did was wrong, basically. Mental disease or defect does not otherwise constitute a defense, and that's the important part. Mental disease by itself is not a reason to claim insanity. Okay, so I will stop there, and I will see you guys on Wednesday.